class, I thought it might be helpful because of the depth of content and some of the unique elements in terms of coding circulatory system procedures that I give you some additional audio presentation to accompany the information you have here in the class. So if we look at chapter 11 in your textbook, that is a chapter that relates to the circulatory system. These are the PowerPoint slides provided by the publisher, and they follow very much along with the layout of the chapter. So they talk about the body part system, the body system values, the second character values. You don't have to memorize that, but these are things that you should be paying attention to as you are coding to make sure that the character value relates to what you're coding. So if you're coding a procedure on the heart and you end up with a second character value of 3, you would know that perhaps you are not in the right area, you're not coding it correctly. But you don't need to memorize these values. These are something you would see on the table, but you need to pay attention to that to make sure you're coding the right component of the circulatory system. And your textbook chapter goes on to talk about the functions of the system. This should be review, but it's a good idea to look at it again, make sure you're totally getting the understanding of the physiology component of the circulatory system along with the organization, which is also in your textbook. And again, as a coder, I find it very helpful to have pictures. They do provide you with a picture of the heart, of the internal structures, a basic picture of the heart on figure 11.1. It shows you where the pulmonary artery is, the aorta. It talks about the superior vena cava. It identifies for you the valves of the heart, the mitral valve, the aortic valve, the pulmonary valve. And it also gives you a listing in your textbook of all the various components of the heart broken down for you. And again, information about the valves, the different types of valves, the tricuspid, the bicuspid, and the pulmonary and the aortic valve. Gives you definitions and some anatomical references in terms of what is the aorta, what is the vena cava, the pulmonary arteries, and the pulmonary veins. Figure 11.2 shows you the arteries and the veins of the heart. Remembering that arteries are larger, veins are smaller. Other heart structures are noted for you also in chapter 11. The atrial septum. The textbook talks about the conduction mechanism, capillary muscles, the pericardium, and the ventricular septum. Then we have information about the upper and lower arteries. These are tubes that carry blood away from the heart to other structures. Arteries then branch down to smaller arteries and eventually into capillaries. Capillaries are where blood is exchanged with cells. You have many arteries in your body. You have the abdominal aorta, which is one of your arteries. Typically, arteries are named for the areas or organs that they supply with blood. There's a coding tip also in your textbook about the dividing line from a coding standpoint between upper and lower is the diaphragm. That's what we consider the dividing line. Everything above it is upper, everything below it is lower in terms of your diaphragm. Then, of course, 11.4, your textbook picture 11.4 talks about your upper and lower veins. Veins are large tubes that carry blood to the heart after it has been collected from the capillaries or small veins. And then it starts talking about some of the different procedures related to the cardio system or their circulatory system. The first one of those is what we affectionately call a CABG, or coronary artery bypass graft. And they give you a picture of one in the figure 11.5. We can also do tissue grafts as part of that CABG procedure. Typically, when a patient's having a CABG, they have some element of their heart blocked, typically an artery. So they're going to take typically a vein from the patient themselves. So the patient's going to self-donate. Typically, they take the saphenous vein from the leg, the greater saphenous vein, and they graft a bypass. So they basically reroute, like on a highway. They're going to reroute and create a new pathway because this patient has heart blockage. A patient can have multiple bypasses done of 4 vessels or 4 CABG times 4. They can also have a CABG times 1. So it depends on how severe their heart blockage or their areas of their heart that are blocked off. Typically, they're blocked off by plaque, and it's better to bypass than to try to remove what's clogging, so to speak, their arteries. Also in chapter 11, it talks about devices. Patients often will have pacemakers. We'll have some examples of coding of pacemakers at the end of this chapter. There's different types of pacemakers. There's single chamber in general and dual chamber. You do need to know that piece of information, and because this device is left in the patient at the conclusion of the procedure, you would be reflecting a positive value for the device character. Other devices include defibrillators, and there's different kinds of defibrillators as noted on the slide and in your textbook. Also, there's a coding tip in your textbook. It talks about pacemakers specifically. Typically, we need at least 2 codes for a pacemaker because a pacemaker is not a singular device in terms of it's just one piece. Pacemaker has 2 pieces. It has what's called a generator, which is typically a disc-like device. That's the heart of the pacemaker. That's where the mechanics of it are, so to speak. And that's where the battery is. And coming out of the generator are leads that go into the actual structures of the heart. A pacemaker is typically placed right below the skin. The leads then go into the heart, further into the body. So we need 2 codes typically for a pacemaker. We have to code the placement of the generator and the placement of the lead. Now there could be more than 1 lead. A single chamber pacemaker only has 1 lead. A dual chamber pacemaker has 2. So the more leads you have, that could be a factor. But you do need at least 2 codes for a pacemaker insertion. The next device that your textbook talks about is a heart assist device. It can be implantable or external. Heart assist devices have a conduit that moves blood from the left ventricle to the systemic circulation through the aorta. The aorta was that large arch of your heart. The device uses a pump to perform this function. Some heart assist devices are bivalvular, means they have an additional conduit from the right ventricle to the pulmonary arteries. They have 2. These devices either allow the heart to rest while it heals or allow patients to function while they are waiting for a heart transplant. You also have in your textbook, they talk about the inferior vena cava filter. An IVC is a ventricular filter that is placed using a percutaneous approach into the inferior vena cava. It is meant to stop the movement of emboli from the lower extremities through the venous system into the heart and lungs. And an emboli is a clot, a blood clot. For our VADs, or vascular access devices, The reason why a patient would have that is to provide access for infusion. So a patient who is going to be under some type of treatment is going to be more than one event. So it's going to be like a cancer treatment or possibly some other type of device or some other reason that they're going to need infusions over the next 6 months. Maybe they have some type of blood disorder. There's a variety of reasons why a patient would need access for more than just one day. So if we're going to give a patient infusion of drugs or possibly do multiple blood withdrawals over a period of time, we clinically may want to give them some comfort in a sense and have a vascular access device put in so that we don't have to go through their veins to do all this poking and prodding to them for the next 6 months. So you will see patients again who have cancer, patients who have leukemia, patients who maybe have had some type of osteomyelitis, they have a bone infection. They want to give them IV treatment over the next 3 months. So its vascular access device is to provide access for the infusion of substances or the drawing of blood or both. Typically, they fall into various categories. You have veins and catheters, ports, and pumps. Access via vein, access via catheter, something called a port, and a pump. Patients who go in for an IV, may go in the hospital in the morning, get an IV, have surgery, have outpatient surgery, have an IV put in to give them saline, give them some medication, anesthesia, so they can go to sleep during their outpatient surgery, but they're not intubated, nothing's going down their throat, what we call twilight or conscious sedation. Those type of peripheral IVs are not coded. Typically, they're not done by a surgeon. They're typically done by a nurse or a nurse anesthetist. So typically, short-term, what we would call peripheral IVs that are placed in the hand, the arm, the foot, or the leg are not coded. However, things like PICC lines, central venous catheters would be coded. Tunneled catheters such as a Hickman catheter would also be coded. Indwelling ports would definitely be coded. The most common example of a port or a pump would be a patient who is maybe diabetic. An insulin-dependent diabetic could have an insulin pump put in. These are examples of why you would code these things. And these are typically done by a vascular surgeon. Next area they talk about are heart valves. You have multiple valves in your heart. You have the mitral valve, the aortic valve, pulmonary valve, etc. Sometimes those valves break down. Sometimes patients are born with valves not working correctly, and they can be repaired or replaced typically. They also can dilate the valves to make them work better. Dilation techniques include balloon dilation, and it's important to remember that if a patient is having a dilation of a heart valve, the balloon is not going to be left inside their body. The balloon is put in to open up the area, but we can't leave it there because that would block off their heart and block off their cardiac flow, blood flow. We can also replace the valves. We can do a mechanical replacement, or we can replace their valve or part of their valves with animal tissue. Typically, pig tissue is used, and that would be a zeoplastic type replacement. And then we have the TAVR, which is the transcatheter valve replacement. Which is also discussed in your textbook. The creation root operation is also something that could be used in the circulatory system coding. The root operation of creation is used to describe the process of forming a new body part to replicate the structure or function of an absent body part. This is most commonly used when you have babies who are born with congenital heart defects. The most common one she talks about in your textbook is the AV canal deformity, where the central portion of a baby's heart has not developed correctly. The infant is missing parts of the septum that separates the chambers of the heart. A septum is a separation. It's typically a membrane-like structure. You have a nasal septum in the middle of your nose, the same idea, but this is we're talking about the heart. Then the other element of heart coding or vascular coding is aneurysms. Aneurysms are within an artery. Typically, you can think of it like a bubble almost inside the artery. So there's like a bulge in the artery wall that makes it bulge out. Your textbook calls it an outpocketing. There's different ways to treat aneurysms. Depends on where the aneurysm is, but there's multiple ways to treat most aneurysms. There's not just one method. So that means from a coding standpoint, there's going to be possibility of different surgical approaches. Some aneurysms are not treated right away. Some are monitored. Some are treated with some short-term device, and then possibly something more severe in terms of surgical event. A more involved operation is done later because the short-term device didn't do what it was supposed to do, or now the patient's had that for a while and they need to move on to the next step. Some locations, depending on where the aneurysm is, the objective of the procedure is to cut off that area. Sometimes you can't cut that area off. You can't occlude it, because if you occlude it, the patient will have no blood flow to that part of their body. So it depends on the location, the surgical treatment, and of course all of that goes back to documentation. Mapping procedures are used for coding, or used to identify and give some clinical information. Mapping is done typically in the cardiovascular area for intraoperative cardiac mapping as part of open heart surgery or during a heart catheterization. Mapping is done to identify the exact location typically causing an arrhythmia, such as an atrial fibrillation. The map component would be coded separately in addition to anything else that was done, if it was done and documented, during the heart catheterization, for example. Of course, a heart transplant is removing the patient's diseased heart and replacing it with a donation from a cadaver or someone who has been identified as brain dead. Then we have heart catheterization. A cardiac cath or a heart catheterization is a percutaneous procedure. They typically go in through the femoral vein. They make a small puncture and they put in a guide wire up the patient's leg to their heart. So they're not attacking or addressing, they're not cutting into the patient's chest. It's a percutaneous procedure. And they give you examples in your textbook of coding of these particular procedures. If they're going to monitor the patient's heart pressure as part of this heart catheterization, typically the patient has a small clot or some type of plaque. They're going to go up and bust out, typically with a balloon. But sometimes, depending on the situation, clinical information, they may also want to do measurement and monitoring. and that would also be coded with a code from that particular section of ICD-10 PCS. In this case, at this moment, we're coding the surgical event, which is that percutaneous approach, something that causes a cutting into the patient. PTCA, percutaneous transluminal coronary angioplasty. It denotes for you in your textbook that the root operation dilation is used when the objective is to mechanically widen the narrowed or obstructed blood vessel, and this is often done. The PTCA is often a type of cardiac catheterization. The coding guideline of B4.4 relates also to PCTAs. It talks about, that guideline talks about coronary arteries are classified as a single, coronary arteries, plural, are classified as a single body part that is further specified by number of arteries treated. One procedure code specifying multiple arteries is used when the same procedure is performed, including the same device and qualifier values. So when you're coding these PTCAs, if it's more than one artery, you have the ability to identify how many arteries were addressed in that procedure, and you end up with one code. So if the patient had 2 arteries, you could potentially, depending on the situation and documentation, you could have one code, because in the code itself, you identify, one of the character values is going to identify how many arteries. I'm going to give you some examples in your textbook. Then again, they talk about the CABG, coronary artery bypass graft. In this particular case, this particular procedure has some unique elements of coding it, and we'll go through some examples of that in the exercise portion of this class, and this lesson specifically. Typically, patients don't have just one artery bypass. They have at least 2, but it could happen that you could have 1. And we also are going to have some type of a device. Typically, it's the patient's own vein being used, or another part of their heart anatomy, and another part of their artery tissue. But we can also perhaps use some zeoplastic tissue. Again, zeoplastic means that it's donation from another animal species, non-human. And then we also, in addition to just heart bypass, you can also have bypasses in your extremities, such as a femoral fempop or femoral popliteal bypass, which would be in your leg or your knee. And then we move into the AV fistulas. The most common reason for a patient to have an AV fistula, or really the only reason I know of at this point, is for hemodialysis. And this is coded as a bypass. The fistula is a direct connection of the vessels and grafts to help facilitate the hemodialysis process. And a patient, typically, these are the AV fistula or something that's going to be used when used for the hemodialysis process. So it often, unfortunately, happens that the patient will get a thrombus, or get a clot. So you would need to understand what that is and how to code that. And that then goes to a different root operation, because the patient's already had the fistula created. Now they've got basically a complication of the fistula, which is a blood clot. And the root operation extirpation is used to describe the process of declotting tubular body parts within the circulatory system. Clots are considered an abnormal byproduct of biological function. Common root operations, of course, include extirpation, again for declotting, embolization, for occlusion and restriction. Just one caution again for your embolizations, you want to make sure you understand physiology or review the operative report. Make sure if you're coding something occlusion, that means you're closing off that area of that patient's vessel completely. That's what the intention is from the surgeon, and that's what's documented. So you don't want to be assuming it's occlusion, because you closing it off means you're not letting anything flow through that particular tubular body part. We also have more common route operations or supplement. That would be for your heart valves, perhaps. We have mapping, drainage. If we're moving blood directly from the heart, from artery or vein. But again, we don't code just normal IV blood draws. For our body part values, your textbook talks about, gives you a lot of tables. Again, you don't need to memorize them because you would have that information at the table in your ICD-10 PCS coding manual. But body part values are available for a variety of different arteries and veins and their associated branches. So again, it may be helpful for you to have pictures when you get into some more detailed operations. And you have some of those graphics here in your textbook, so you don't have to go looking for them specifically depending on what operation you're actually coding. For body part values, generic body parts are available also, in addition to specific ones. Since there's so many arteries and veins in our bodies, especially when we get into our hands and feet, we do have the ability for using generic body part values. And remember, your dividing point between upper and lower anatomically from an ICD-10 PCS coding standpoint is your diaphragm. Surgical approaches common to the circulatory system include open, percutaneous, endoscopic, and external. Devices, again, we're going to reflect a positive value when we're at the coding table if a device is left in the patient at the conclusion of the surgery and it's not a minimal device, so it has to be something other than a drain, or the physician went in specifically to work on a device, so something that's malfunctioning. Qualifiers in the circulatory system, you do have that unique component, which you'll see when we look at the exercises for bypass procedures, specifically CABG, for example. And there is also guideline B3.6C that talks about separate codes for different devices and our qualifiers. Drug-coated balloon is a type of device that will deliver medicine over time. It goes into a vessel and is not reflected in the device character value. That's a unique element of this particular. It is a device, but it's reflected in the qualifier value on the 047 table. It is not a device that's left in the patient at the end of the procedure. Again, it's a balloon, and it's assigned in the 047 table. It's reflected, or the use of it is reflected in the qualifier value for that particular code. Then here we have one example. We have the case study number 2. So you have to go past the code building exercises, go past the check your understanding, to get to case study number 2. This is one example of the treatment of an aneurysm. This particular patient has what is called a AAA, an abdominal aortic aneurysm. This particular slide identifies to you the body part and the body system. You have some information about the patient in terms of their background, history in terms of what's happening. Then we have the main component of the operative report, which again your textbook authors call them case studies. So the physician makes a transverse groin incision into the leg area. They use an entry needle. They use a guide wire, was introduced in a 5 French sheath. They also then ended up doing a catheter. They use a insertion of something called a gore excluder. Was inserted. The balloon was inserted and the proximal distal attachment sites were ballooned as well as the floor divided. They're talking about the floor of the artery. An angiogram, which is a picture, showed that they had excellent flow through the excluder graft with no leaking. So they put something into this patient because this patient has an aneurysm. And then they found out that the aneurysm sac, they didn't actually remove the aneurysm. They're trying to restrict the blood flow to it. So they put this device in the patient to do that. So what is the objective of this procedure? The objective of the procedure is to close off this body part vessel to restrict the size of the aneurysm, to restrict the size of what the physician called an aneurysm sac. The location is the abdominal aorta, lower part of the patient's body. The device they used was an intraluminal. It went inside the artery. And when we go through the coding steps, we index the main term of restriction. The location will be our subterm, the anatomy. And it was done percutaneous. Part of the information we were given. Let's go back. Percutaneous approach. We end up with the code of 04B03DZ. So that is the conclusion of the lecture. Audio to accompany the PowerPoint slides. Please also look out for the information on the case studies, which is a forum posting, and also the other exercises at the end of chapter 11. Any questions, please let me know.